Okay, I would be
Now,
speaking on newer lasers and lasers for post-operative glaucoma management. So in the newer lasers, we have the endoscopic cyclophotocoagulation, micropulse has been talked about, and the class laser. So coming on to ECP, so endoscopic cyclophotocoagulation is a minimally invasive glaucoma procedure in which an endoscope is used to directly visualize the ciliary epithelium and photocoagulate it using a guided laser delivery system built into the endoscopic probe. As the laser energy is precisely delivered to the ciliary processes, there is no damage to the underlying ciliary body and surrounding tissues, and therefore it decreases the IOP by reducing the aqueous inflow with least complications. So, if we compare ECP versus the traditional DLCP, the because it is directly photocoagulating, the laser power is zero point 0.2 watt versus 2 watts. It's nearly one tenth of the laser power, and therefore the complications till date reported have been minimal versus to that of the traditional one. So if you look at the machine, this is the video display output where you see what you're lasering. This is the actual control unit, the laser source, and then the most important thing, the star, is the endoscopic probe, which has a high resolution camera along with the aiming beam inside the probe. So we can use a limbal as well as a pars plana approach, but being an anterior segment surgeons, we prefer to use the limbal approach. So I will just be showing videos wherein we do the procedure. The most important thing is to use a visco-cohesive OVD that is injected into the sulcus area to widen the sulcus, and then we put in the probe and target the ciliary processes, and the endpoint is whitening as well as shrinkage of the ciliary processes. So I'll just discuss a case scenario. This was a case of a primary angle closure with cataract. So we plan to do a phaco versus ECP. So this is a small video clip. This is not running. So till they're can you fix it? So till they're fixing it, so we do a routine phaco emulsification. And after doing the routine phacoemulsification, the one thing is that we have to first insert the IOL. After inserting the IOL, we have to inflate. Okay, we have to inflate the ciliary sulcus with a viscocohesive OVD, and then we put our laser probe in the either 23 gauge or 20 gauge or 19 gauge, and we aim each of the ciliary processes. So this is another case scenario in which we are just doing a simple ECP, not with phacos. This was a case of a 57-year-old female who was operated VR surgery, and silicone removal was done, and she had a lot of scarring also along with silicone oil and AC. So we were thinking in terms of doing a ECP. So again, there is some problem in any which ways. So in this we can see in the video that there's a silicone oil globule. So we just first make two MVR entries, put a high cohesive viscoelastic, inflate the sulcus, and then direct the probe into the onto the ciliary processes. So important thing that we have noticed when we are doing in cases of such cases who are towards refractory side, we have seen that the ciliary processes of these patients are usually atrophic versus to what we are doing in angle closure glaucomas. They are very healthy. So that is why in these patients the laser uptake is slower. It is very slow. You have to wait for the laser to actually for it to shrink and for the whitening to happen, versus the normal patient, the versus the healthier eyes where we just put the laser probe and it just shrinks. It is just like a wow effect in those patients versus these patients. So at the end, I think I'll show the video separately. So we have done a study in our center where we have seen 26 eyes of 26 patients who had undergone phaco ECP in cases of mild moderate to severe angle closure glaucomas who had visually significant cataract with patent PI. And we have seen that in both 3 and 6 months there was a significant control of IOP and significant reduction in intraocular pressure in the number of medications as well. The complication that we have noted is we have noted fibrinous uveitis in 2 patients. However, it subsided with topical steroid use within a week. So in one patient, the patient did not use the antibiotic steroid combination, But in the second patient, the patient claimed that she was using. We also don't know why this happen, but subsequently we did not see in any of these patients. So these were probably the initial patients. Maybe we were learning and the laser setting was on the higher side. But on an average, the laser setting that we are using, that we have used is between nearly zero point 0.3 watts. Then we have nearly 10 patients whom we have done only plain ECP. These are all refractory cases in which we have done plain ECPs. We have seen that in these, at least 3 patients required repeat procedure or required another surgery. After 6 to 8 weeks, we had to do that. So if you look into the efficacy of there are various studies also wherein they have seen that phaco versus ECP versus phaco alone. The ECP was a very, phaco ECP was had associated with a significant reduction in IOP along with a significant reduction in number of medications as well. And if you look at safety studies, there are very low incidence of complications, and that till date, whatever limited data we have. So next is the class, that is the carbon dioxide laser assisted deep sclerectomy. So this is a normal trap flap we make, and then we use the CO2 laser. And since it is a laser, so it is a very graded procedure. Otherwise, in deep sclerectomy, we know it is very surgically demanding procedure. You have to be very thin layers you have to do. So here the laser will go to that particular depth only, and then you can just close the scleral flap. So CO2 laser ablation system also allows precise and easy creation of the scleral space and ablation of the Slem canal. And this technique has been shown to be efficient as a standard non-penetrating glaucoma surgery in lowering IOP. Also, if you look at the complete success rate at 12 months, it is nearly 50%, whereas qualified success is nearly 90%. So next, what is more important is that once you have done a surgery for the patient, we being glaucoma surgeons, we are always, very apprehensive post surgery, because surgery is just the first milestone. The rest of the milestones and the picture abhi baki hai. So the rest of the milestones are yet to be shown. So lasers are very handy in that, and it is a lifesaver for us surgeons. So one is laser suturolysis. For this, we use the Nd:YAG 532 nanometer. This is the retinal laser that we use, and the spot size is 50 to 100 microns at a 300 milliwatt. So this is the lens that we are using. This is the Hoskins lens, and this magnifies the suture. It compresses the suture, blanches the conjunctiva, and you can see the slightly magnified suture. This is how we put the lens. And this is a magnified view. We have done we can see there are two fixed sutures that has been put. Even after that, the bleb is failing. So then we put this lens, and then just a single spot, you can see there's a gap. The suture, you can just see the suture, just like, it gives way. And then you do a good massage, and then you can see from the pre and the post, there's a diffuse bleb that has been formed, and immediately within 20 minutes you take the pressure from 30 pressures, it has come down to 12 pressures. Next is the lasering of the bleb. So gentian violet dye is used to stain the bleb surface and enhance the laser absorption. Laser spots are then applied over the entire bleb surface to shrink the bleb. So this was very handy during the COVID period, because many patients, they could not frequently come for follow-up, and many patients were scared during that time. So we had patients who had come presented with such overhanging and avascular blebs. We did this, and we got very good results. In this, we can see such a huge bleb. This has actually shrunk down, and the patient is doing well only on an antibiotic now. Next is malignant glaucoma. So malignant glaucoma is the dreadest, nightmare for a glaucoma surgeon. So we first initially give all the conservative management like cyclophotocoagulation, aqueous suppressant steroids. But doing a laser is like a magic. If within 1 or 2 days, even after conservative management, nothing happens, if you just do a laser and make a unique cameral segment wherein the fluid can flow from the posterior segment to the anterior segment, the anterior chamber magically starts forming and the pressures magically starts coming down. So definitely YAG laser capsulotomy and YAG hyodotomy and YAG PI in such patients have done wonders. Lastly, in patients where we have done trabeculectomies, and the patients are either they are not adherent with the medications and all. Many a times it has happened that the patient comes to us with the iris that is stuck into the ostium with a relatively shallow AC in the early first week. You don't want to enter the eye at such a position. You are in like a state of catch 22 situation, what to do and what not to do. Laser is a savior in this. We have put a single spot of laser after putting pilocarpine, and how wonderfully this has opened up. So this is again a life saving procedure. Then this there are few different cases that comes to us. So this was a case of a implantation cyst post traumatic. The patient was a young 20-year-old male who had gone to several places with this, and he had presented with a borderline pressures of 22 millimeters of mercury. And he had, typically his problem was he can see in the distance, but when he looks down he has difficulty in seeing. So we all know that for these implantations surgery is a big no. You cannot it is unpredictable. He's phakic, he's young, you don't want to go in. So we were like, why not, let's give a shot of laser and see. We gave a single shot of laser. Within few minutes it shrunk. Till 3 months, this is 6 months, the patient is doing well. Till 1 year follow up, he's on single drop beta blocker till now. So to summarize, I would like to say that in lasers, ECP directly ablates the ciliary processes, requiring lesser power and therefore lesser or minimal complication. So therefore, ECP seems to be a simple, safe and effective procedure, especially when you are doing as an adjunct with phacoemulsification surgery. In one go, patient can uh, get the power of getting good vision, as well as reduction in the number of medications and improving the quality of life for these patients. And in post-operative glaucoma management, laser definitely is the third hand of the surgeon, and it has a very important role to play. Thank you for the patient listening.
Thank you for covering all the newer advances in laser in a very concise manner. Ma'am, I would like to ask which laser we are using for the overfiltering blip. The same.
Overfiltering the honey, wo laser, that is the retinal laser.
That is the retinal
Retinal
laser.
laser, 532 nanometers Nd:YAG laser.
Same for the suture risers
Yes,
and
same
for the
same
blip.
for
Same.
the